So, good evening, everyone. Welcome to today's webinar. We are delighted to have all of you here in this session. So, it's my pleasure to introduce our distinguished speaker today, Dr. Amit Goel. Dr. Amit Goel is the Director and Head, Kidney Transplant and Uro-oncology, Robotics, Urology at Max Super Speciality Hospital, Gurgaon, India. So, with overall experience of more than 23 years, Dr. Amit Goel did MBBS, MS, and then MCH from IPGME and R, Kolkata. So, Dr. Amit, he has a vast experience of treating over 3,500 urological cancers and more than 500 kidney transplant, both ABO compatible and incompatible. So, Dr. Amit, we truly appreciate you taking out the time to share your expertise with us today. Thank you, sir. And
Thank
as I already mentioned, we have our translator Yaobi with us. He will be helping our doctors from Congo to follow up along smoothly. So, yeah, uh, over to you, sir.
Thanks,
Bonsoir à tous
Shivanshi.
et merci de nous rejoindre pour la séance d'aujourd'hui où nous allons avoir Dr. Amit Goel qui est urologiste et qui va nous parler des reins et de la transplantation aussi. Merci à tous.
Shall I proceed?
Yes, doctor, we can
Yeah,
start.
yeah. Thanks, Shivanshi. Thanks for the introduction. So I'll directly start with the PT. So basically, the cancer of the prostate, the incidence is, uh, it varies in different region of the world, where the maximum incidence that we find is in Northern Europe, and it's very less when it is in South Central Asia. And the incidence, it increases as we age, and it becomes more common in men after age of 65 years. And men of African descent have a very high risk of prostate cancer, as if we can compare with any other ethnicities. This is they have the maximum risk of prostate cancer. So today we have a lot of African people, and sorry, I should have actually welcomed you everybody for the webinar, and greetings from Gurgaon. So and in India also, the prostate cancer is the second most common cancer in men, and there are something like 40,000 new cases that have been reported in 2020.
Le cancer de la prostate varie selon plusieurs spécificités. Nous pouvons mentionner que l'incidence est plus élevée en Europe du Nord, alors qu'elle est au plus bas en Asie du Sud. Et l'âge aussi est un facteur important vu que le cancer touche plus les hommes de plus de 65 ans et les hommes d'ascendance africaine sont les plus à risque de développer cette maladie. Et nous pouvons aussi mentionner qu'en Inde, nous avons en 2020 plus de 40 000 cas de cancer de la prostate.
So coming to the risk factors, so increasing age, family history, African American descent, and dietary factors are the risk factors for prostate cancer. And there are some nutritional things that are protective against prostate cancer: soy protein, lycopene, vitamin E, selenium. So this has to be inculcated in the diet. There are certain there are some genetic correlations also that leads to high risk of prostate cancer. That is like the chromosome 1 band Q24 aberration, if it is there. So then there are higher risks of having prostate cancer in the men.
Nous avons des facteurs importants qui peuvent avoir aussi des incidences sur le cancer, à savoir l'âge, la famille et aussi l'alimentation. Il y a aussi le facteur génétique qui peut être important et aussi la race. Nous l'avons mentionné plus tôt, les hommes d'ascendance africaine développent plus ce cancer comparé aux autres races.
So, if coming to the pathophysiology, so most of the cancers of the prostate are adenocarcinomas, and they develop in the acini of the prostatic ducts. And there are some rare varieties of prostate cancer, also small cell variant, the mucinous carcinoma, endometrioid, transitional cell cancer, squamous cell carcinoma, signet ring carcinoma, neuroendocrine cancer. So all these are the rarer variants of the prostate cancer.
Nous pouvons mentionner que l'adénocarcinome est plus répandu, occupant 95% des cancers de la prostate, et nous pouvons avoir quelques rares cas où le carcinome est impliqué.
So this is how the region of the prostate have the susceptibility to the cancers. So peripheral zone, that is the zone that is shown in the orange. This is the peripheral zone. You can see it as the marking is there, and this is the most susceptible zone to have prostate cancer. So transitional and central zone, they have a lesser incidence of harboring prostate cancer.
La zone périphérique de la prostate est la plus à même de développer le cancer. Nous pouvons voir que ça occupe plus de 70% et cette zone est marquée en orange sur l'image, et la zone médium et la zone interne sont moins à risque de développer le cancer.
Hello. So coming to the clinical manifestations. So most of the prostate cancers that we find are organ confined, and they are early stage. And because of the advent of the PSA screening, we find we have early detection of cancer. That means when the cancer is organ confined.
Nous arrivons à détecter le cancer de la prostate à un stage assez tôt dans son développement grâce aux techniques de détection, et nous pouvons détecter des cancers qui sont même asymptomatiques.
So we can have other presentations as well if there is a locally advanced cancer. So there might be obstructive voiding symptoms. So where there can be hesitancy, there might be intermittency in the urinary stream, decreased force of the urine, and also there might be sometimes blood in the urine or blood in the semen.
Des facteurs beaucoup plus avancés peuvent aussi permettre de détecter le mal, à savoir le facteur lié à la fréquence de l'urine, quand on a des urines intermittents, et aussi quand le débit est réduit.
So we sometimes have the disease gone into the pelvic lymph nodes, and because of which the patient sometimes present with edema of the lower extremities and sometimes pelvic and perineal discomfort.
Des disconforts dans la zone pelvique aussi peuvent être un signe.
So there can be metastatic disease presentation where the disease has already gone into the bone. So bone is the most common site for metastasis, and it can result in pathological fractures and the spinal cord compression, and that event sometimes leads us to the diagnosis of prostate cancer, that there is already some metastasis that has happened into the vertebral column. So this is also this is the most common presentation of the metastatic disease.
L'étape métastatique de la maladie peut toucher les os et c'est ce qui arrive beaucoup plus fréquemment et ce qui peut causer des dommages qui sont irréversibles et une douleur assez élevée.
So even sometimes the metastasis can happen in the lungs, liver, into the pleural cavity, peritoneal cavity, central nervous system. So this normally we find when after we have given the hormone therapy. So then we find this sort of metastasis. Okay. So coming to the how do we detect the prostate cancer? So first and foremost is the PSA level, and as I said, most of the patients are asymptomatic, at least in India, and we diagnose the disease by doing PSA screening. So any patient who walks into the clinic, into the urology clinic, we get the PSA screening done for that patient. So if it is 55 years plus age, we tell them that we are doing a PSA test for you. And if the PSA level comes up to be high, then we have a suspicion that it might be a prostate cancer, and we go in for the further examination and further tests for the patient.
Étant donné que la plupart des patients sont asymptomatiques, nous procédons à un scanner pour détecter la présence du cancer de la prostate.
So sometimes while examining the patient for a prostate issue, we because we examine every patient who comes to the clinic for some problems with the urine. So all the males who are examined, so sometimes we find a palpable nodule, hard nodularity in the digital rectal examination, and if we find a hard nodule in the rectal examination, we do a biopsy for that patient.
Nous pouvons aussi procéder par palpation si nous retrouvons des nodules présents au niveau de la prostate. Cela peut aussi servir de preuve de la présence du mal.
So sometimes the patient come with symptomatic disease also where there is obstructive voiding, some pelvic pain, edema of the lower extremities, and sometimes bone pains. And this is when the patients get diagnosed. We have the suspicion of a prostate cancer, and then the patients get diagnosed with the cancer.
Des fois aussi, nous avons des patients qui sont asymptomatiques, mais qui sont à un état avancé et nous pouvons voir des symptômes de douleur au niveau pelvique et nous pouvons aussi voir des symptômes de lésion des os.
So this is what actually the digital rectal examination. So I think most of us know how a digital rectal examination is done. So with the gloved finger, we introduce the finger into the with the jelly, we introduce into the rectum, and we try to palpate the prostate gland, and we can palpate the peripheral zone of the prostate by this examination. And if there is a hard nodularity, then there are nearly like 50% times 50 to 55% times we have a prostate cancer. So we do biopsy for any patient who's having a palpable nodule on the digital rectal examination.
Nous procédons aussi à de la palpation ou à de la biopsie pour les patients qui ont une sensitivité réduite.
So we do a transrectal ultrasonography. That is, we put a probe through the rectum inside and do the biopsy, transrectal ultrasound guided biopsy is done for the patient, and whenever there is a high PSA or there is a hard nodule, this is what is the standard of care. So we are doing transrectal ultrasound guided biopsies for this patient, and nowadays even uh, there is MR transfusion biopsy. So where we do MRI, a special MRI is done, multiparametric MRI, and if there are some suspicious region on the MRI, we fuse it with the ultrasound in real time and take biopsies from the suspicious zone.
Procédons aussi par des IRM quand nous avons des suspicions ou aussi par des biopsies par ultrasons, ce qui peut aussi permettre de détecter la présence des cellules.
So normally we do a 12 core biopsy, and then if there is a suspicious region, we take some extra biopsies from that. So mainly 4 biopsies. Hello. Yeah. So normally we do 12 core biopsy, which means 4 biopsies from the base, 4 from the mid gland, and 4 from the apex. And for this thing, I'm doing the biopsies myself for all of the patients, so that we have the accuracy, and the biopsy is targeted wherever the lesion is seen in the ultrasonography.
Nous procédons souvent à 12 biopsies pour plus de sécurité et nous ciblons les endroits susceptibles d'avoir des lésions.
So this is how the transrectal probe looks like, and then we insert a needle through this. So this is the probe which can see the prostate, and in real time we introduce the needle inside the prostate and take biopsies from this.
Donc, voici comment ça se passe. Nous introduisons l'appareil pour effectuer la biopsie comme ça.
And this is how the perineal biopsy is done. The biopsy is not done through the rectum; it is done through the perineum directly. This needs anesthesia; it has to be done under general anesthesia.
Et voici comment la biopsie du périnée est faite et nous avons besoin d'anesthésie générale pour procéder à cette biopsie.
So this is how we get the biopsy reading. So on the biopsy, we find that there's a Gleason score, so which gives us how aggressive the cancer is on the microscopic examination. So grade 1 being, grade 1 and 2 we don't consider as cancerous, but grade 3 to 5 is considered minimally aggressive to very highly aggressive prostate cancer.
Voici comment nous procédons à l'évaluation. Donc, au niveau de l'étape 1 et 2, nous ne considérons pas que ce soit agressif, mais à partir de l'étape 3 jusqu'à l'étape 5, nous considérons que c'est assez agressif.
So this is just a picture how the glands arrangement is. In 1 and 2, it's like more of a well-defined arrangement, and then as it goes to 3, 4, and 5, it becomes poorly differentiated. So what is the advantage of doing a Gleason score? So it is of paramount importance to see what is the Gleason score of the patient with the cancer of the prostate, because our treatment is definitely based on how bad is the Gleason score of the patient. So in Gleason score, normally we take like the most common Gleason score, the most common biopsy, and then the second most common. So if we take it for the most common is like if it is 4, the second might be the lesser common might be 5, or it might be that the most common is 5 and then lesser common is 4. So we do a addition of the two the biopsy scores, and then it gives us a proper Gleason score. So whatever score comes, it is out of 10. So it can be ranging from 6, 7, 8, 9, or 10, depending on what is the primary core and the secondary core.
Donc, nous procédons avec la méthode du score de Gleason qui nous permet de faire plusieurs mesures et de nous servir des deux mesures les plus répétitives pour obtenir une moyenne, et cela nous permet de savoir l'étape à laquelle le mal est.
So as I earlier said, so this can be Gleason's group 1, where it is 6 or lower. Gleason group 2 is 3 plus 4, that is 7. Gleason group 3 means it is 7, but here the most common is 4 and the lesser common is 3. Gleason group 4 is 4 plus 4, and Gleason group 5 is 5 plus 4 or 5 plus 5. So this is how we get the biopsy reports.
Donc, les résultats nous donnent cette catégorisation. Pour le groupe 1, nous avons les scores de 6 ou moins. Le groupe 2 sont les scores de 7, mais avec 3 étant le score le plus commun. Et la catégorie 3, toujours 7, mais avec 4 étant le plus commun. La catégorie 4, quand nous avons 2 scores de 4. Et au-delà de 8, nous rentrons donc dans la catégorie 5.
So as I said, we do a special MRI of the prostate, and this gives us a fairly good idea, is the prostate having cancer. But yes, of course, the biopsy has to be done before going in for any sort of treatment, but it gives us a fairly good idea about can this be a cancer or not. And also we do a PSMA PET or a bone scan. So PSMA PET is a prostate specific membrane antigen PET scan. So it is very specific to the prostate cancer. This we do before for the final staging, and then we go ahead. So this tells us if there is a distant metastasis of the prostate cancer.
Donc, au-delà des IRM que nous faisons euh, et de la pyrolyse, nous faisons aussi un scan PSMA et aussi un scan des os pour avoir beaucoup plus de certitude en ce qui concerne les résultats que nous avons.
So how do we do the staging? So this is how the staging is. T1 being a non-palpable prostate cancer, T1A being when the prostate cancer is detected in after the TURP for the prostate, and T1C being when it is done because of the elevated PSA. T2 being when there is a palpable tumor on the examination, and if it is involving only one lobe, it is called T2A, and if it is involving both the lobes, it is called as T2B. If there is in T3, if the prostate capsule has been breached, so then it is called as a T3 disease. And if there is local invasion into the bladder neck or the external sphincter or the rectum, then this is called as stage 4, T4.
Les différentes étapes du cancer, nous avons l'étape 1 qui est le fait que le cancer ne peut pas être palpable. Cela ne peut être détecté que par examination. À l'étape 2, nous avons une tumeur palpable. L'étape 3, c'est quand nous remarquons que la capsule de la prostate est endommagée. Et à l'étape 4, donc, c'est quand nous remarquons qu'il y a une extériorisation de cette capsule-là.
So when we come to the N staging and the M staging, N0 is when there is no nearby nodes involved, and the N1 disease is when the local regional lymph node enlargement is there. M stage is metastatic disease, where M0 is no distant spread. M1 is when the cancer has spread to the distant lymph node. That means not the external iliac, internal iliac of the obturator when it has gone to any distant lymph nodes. And M1B is when the disease has gone to the bones, and M1C is when it has gone to the distant organs.
Nous avons différentes catégorisations avec les lettres NX, N0, N1, ou alors quand cela touche à l'étape métastatique, nous utilisons la catégorisation MX, M0, M1, et ce qui évolue jusqu'à M1C qui est l'étape à laquelle le mal s'est élargi à d'autres organes.
So now we come on to the treatment part. And prostate cancer treatment is quite a complex thing because it depends on so many factors. So, uh, and there are a lot of treatments that are available. So, uh, we have to have a lot of things in consideration. First is what is the stage of the disease, and then what is the age of the patient, what is the life expectancy of the patient, what is the biopsy score of the patient, what is the Gleason score of the patient, so what are the risk factors that the patients are having. So a lot of things are to be taken into the consideration before deciding the treatment for of the prostate cancer. So I will say it is one of the most difficult cancers to treat.
Donc, je dirais que c'est l'un des cancers les plus difficiles à traiter, vu que le traitement dépend de plusieurs facteurs, que ce soit l'âge, que ce soit l'espérance de vie ou d'autres facteurs qui rendent la décision de quel traitement utiliser assez difficile.
So in the treatment options, so like if there is a localized disease, so we have some treatments available. So and for metastatic disease, we have some different sort of treatments that are available. In the surgery, we everybody knows, so the most commonly done surgery for the prostate cancer is the radical prostatectomy, and that can be done by the open technique, laparoscopic technique, and the robotics. So I will, in the end of the after the talk, I will be sharing about 10 minutes video each of the laparoscopic radical prostatectomy, where the bilateral lymph node sparing has been done, and also the pelvic lymph node, extended pelvic lymph node dissection has been done, both by the laparoscopic and the robotic technique. So I'll be sharing those videos on screen. So please be there if you wish to see that. And after the talk is over, I'll be open to questions. So anybody, if you want uh, to ask some questions from me, I'll be very happy to answer. And also there'll be a number that I'll be showing to you on the last screen, screen that is shared. So you can connect with me on WhatsApp if you feel that you need to talk to me.
La chirurgie la plus étendue pour le traitement, c'est la prostatectomie radicale qui peut se faire de différentes manières, que ce soit de la manière traditionnelle, que ce soit par la paroscopie ou alors par utilisation de la robotique. Et à la fin de la présentation, nous aurons des vidéos vous montrant certaines de ces opérations et aussi des contacts seront partagés au cas où vous aurez envie de continuer la discussion, que ce soit sur WhatsApp ou par d'autres moyens pour avoir plus d'informations.
So for localized disease, we have radiation therapy, that is brachytherapy, as well as the external beam radiotherapy. We have cryotherapy option also. We have androgen deprivation. We have chemotherapy in the form of docetaxel, cabazitaxel, and there are options of watchful waiting and active surveillance also. So this is you can just see how big is the treatment spectrum that we have, and that is what precisely I wanted to say, that the treatment of the prostate cancer is not like a straightforward thing that you get a cancer and you go ahead for the treatment. So there are so many permutation combinations that you have and that you need to give to the patient before you start the treatment.
Dans le cas où le mal est localisé, nous avons plusieurs options de traitement. Ça peut être par radiation, par cryothérapie, par dépravation androgène, par chimiothérapie ou aussi par une attente vigilante ou une surveillance active, ce qui implique plusieurs visites et plusieurs ARM.
So once we give a hormone therapy to the patient, that is the androgen deprivation therapy, and if shall I wait?
Investigation game
No, doctor, there is some
Atwana.
disturbance. Yaovi, can you please tell Dr. Tisharli to mute himself? Leave it. I have muted him. Yes, doctor, you can continue.
Okay. So so in the patients where when there is the disease cannot be subjected to surgery or a radiotherapy, we have to start the patient on androgen deprivation therapy. That means a castration therapy where we give injection to stop the effect of testosterone on the patient's body. So after giving the hormone therapy to the patient, after some time the PSA starts rising again. So that condition is called as a hormone-resistant prostate or a castration-resistant prostate cancer. And in this case, the treatment, there are certain different treatments that are available. So we sometimes give super anti-androgen to the patient. Abiraterone is given to the patient. So, or sometimes we need to give chemotherapy to these patients. So this is what we need to do for the patient who have a castration-resistant prostate cancer.
Dans le cas des patients ayant un cancer de la prostate qui résiste au traitement par castration, nous avons plusieurs types de solutions que nous pouvons apporter qui sont listées ici. Ça peut être par des thérapies, par une manipulation hormonale secondaire ou une discontinuation des anti-androgènes en suivant la thérapie, ou aussi un suivi ou une chimiothérapie qui peut aussi être utile dans ce cas.
So for patients who have a bone disease, and that means that's advanced prostate cancer, we give painkillers, steroids, and there are new therapies that are available, and sometimes there is a lutetium therapy that has come up very well for any patient who has a widespread bony metastasis, and it works really well even in very comorbid patients who have a lot of comorbidities. Any patient who have morbid patients with comorbidities. So lutetium 177 PSMA therapy is working very well in those patients who have a lot of pain because of the widespread bony metastasis.
Donc là, nous parlons des cas de cancer liés qui sont étendus jusqu'aux os, et nous avons aussi ici la liste des traitements que nous pouvons utiliser pour ce cancer. Ça peut être des analgésiques ou des anti-inflammatoires, et nous avons aussi les cas de métastases liées aux os qui sont assez répandus et qui ne sont pas facilement contrôlables par les analgésiques. Donc pour ce cas, nous utilisons d'autres méthodes qui sont listées ici.
So now coming to the surgical part. So for a localized prostate cancer, normally we have two options. One is the radical prostatectomy, or otherwise we can give radiation therapy. But for any patient who has a high risk disease, it is the surgery has its own advantages. And for low risk disease, where so we basically have to do a risk categorization of the patient. So, and that is when we decide what form of treatment is can be given to the patient. So, like uh, uh, the there are certain criteria for deciding what is the patient's score, and depending on that we offer the treatment. So if the patient is in a low risk, there are certain different treatment. If it is an intermediate or high risk, then there are different modalities of treatment that we offer to the patient. So as you can see, there's a D-amico risk assessment scheme where you can see it in the chart how we go in for risk assessment for these patients. Otherwise, there's a CAPRA score where it is including the age. So it is showing that age under 50 and more than 50, PSA diagnosis. So Gleason score, of how much is the score? So, and the clinical stage, and how many biopsy codes were positive. So it gives us a score, and it tells us this is a low risk disease or an intermediate risk disease or a high risk disease. And that is how we decide what form of treatment is best for any particular patient.
Donc, dans les cas les plus avancés où nous avons comme solution une chirurgie radicale, nous devons dans un premier temps évaluer les risques et le score du patient, le score de gravité, avant de procéder à une quelconque intervention. Et nous avons plusieurs facteurs qui nous permettent d'évaluer ces risques. Nous pouvons utiliser le score Gleason dont nous avons parlé plus tôt. Nous pouvons aussi évaluer l'étape clinique du patient et ça nous permet de déceler si le patient a un risque élevé, intermédiaire ou bas.
So there are certain trials. So I'll just tell the gist of it because because of the paucity of time. So I'll just tell the gist of these studies. So there you can just go through the slides, and I'll just tell you what is the gist of the studies that have been done. So there have been randomized controlled trials where it is showing that the radiotherapy and surgery for the localized prostate cancer, it basically for the low risk disease, it is giving equal disease free survival and overall survival. But for any intermediate risk or a high risk disease, it is better to go in for surgery. So radical prostatectomy gives you the best disease free and overall survival if you are comparing it with the radiotherapy.
Nous pouvons voir que dans certains cas, la radiothérapie et la chirurgie donnent des résultats similaires, tandis que dans les cas les plus avancés, la chirurgie est beaucoup plus efficace.
So this is a most recent meta-analysis where radical prostatectomy and radiotherapy have been compared for high-risk prostate disease, and the results showed that cancer-specific survival, not much difference, but when we see that the overall survival of the patient, so if in terms of longevity, definitely the patients do much better when the radical prostatectomy is done for these patients.
Donc, nous voyons ici une étude comparative des patients qui ont été soumis soit à la radiothérapie ou soit à la chirurgie radicale. Et nous pouvons voir que le taux de réussite est plus élevé pour ceux qui ont opté pour la chirurgie.
coming to the surgical technique, so as I said, so we have that conventional technique that was there, was giving a big cut on the abdomen and doing the surgery. But radical prostate surgery, always people have actually dreaded, the surgeons have dreaded because of the bleeding that happens from the dorsal venous complex. So, so this has been very well taken care of by the laparoscopic technique and the robotic technique, and the DVC is can be very easily taken care of by these two techniques. And you will see that in the video also after my talk.
En ce qui concerne la technique de chirurgie, nous avons la plus répandue, la technique traditionnelle, qui consiste à faire une ouverture dans l'abdomen et à procéder à la chirurgie. Mais cela peut avoir des risques de saignement, donc ce qui rend utile les deux autres techniques, à savoir la laparoscopie et aussi l'intervention de la robotique.
So this is a study that has shown that this compared the robotic technique versus the open radical prostatectomy, and I'll go on to the results directly. So it showed that the urinary function score, sexual function score. So we all know that after the radical prostatectomy, there is some chance of leakage of urine for some time. There is some chance of erectile dysfunction also in the patient, and there, of course, the oncological outcome. That means the biochemical recurrence is also there. That is there with any therapy that we give to the patient. Biochemical recurrence means the rise in the PSA. So this was compared in a Lancet study, and I'll come on to the results.
Donc, voici une comparaison des différentes techniques de chirurgie, à savoir la robotique et la prostatectomie. Donc, nous voyons les différentes comparaisons sur différents aspects et nous allons montrer les résultats bientôt.
So this study, the robotic versus open, showed that urinary function is the same, sexual function is the same, but when it comes to the oncological outcome, that means the biochemical recurrence, the open surgery patients did not do that good as compared to the robotic, and that is because of the very precise and magnified vision that we get in the patients who are getting operated by the robotic technique.
Donc, nous pouvons voir qu'il y a des résultats similaires en ce qui concerne les fonctions urinaires et la fonction sexuelle, mais quand il s'agit de la survie en général, nous pouvons voir que ceux qui optent pour la méthode robotique ont plus de réussite comparé à ceux qui optent pour la méthode traditionnelle.
So this is another study where the robotic versus laparoscopy versus the open technique was compared, and we see the results in the form of a trifecta or a pentafecta when we talk about prostate cancer treatment. So trifecta being how is the urinary continence of the patient, how is the erectile function of the patient, and how is the patient biochemical recurrence free. And when we mainly see the trifecta, and also now there is a pentafecta that we see. That means, is there any surgical margin that has come out to be positive? Was there any major complication like bleeding or any other, any damage to the major vessel like the iliac vessels? So that is what we see, or there is any injury to the bowel or the rectum. So this is what we check out in the when we do a comparison of these techniques.
Une autre façon de comparer les résultats des différentes méthodes, nous pouvons parler de la méthode trifacteur qui consiste à évaluer les résultats en ce qui concerne les fonctions urinaires, érectiles et la récurrence biochimique. Nous avons aussi le facteur, l'utilisation du facteur avec cinq facteurs, ce qui ajoute deux autres facteurs autres facteurs que nous venons de citer.
So, according to the results, the robotic and the laparoscopic, they were better in terms of the whatever the blood loss. So, as I said, the control of the DVC is much better because we have pressure inside the abdomen because of the pneumoperitoneum. So, definitely the blood loss comes down drastically. So, that means transfusion is less because of the small cuts that we give because of the minimally invasive technique, robotic and laparoscopic. So the hospitalization duration also is quite less.
Donc, nous pouvons voir au niveau des résultats que l'approche de la robotique est meilleure que l'approche traditionnelle, vu que ça réduit d'abord le risque de perte de sang, ça réduit aussi le besoin de transfusion sanguine et aussi ça réduit la durée d'hospitalisation qui est requise après l'opération.
So, so this is another study that was published in 2018, and this showed that robotic assisted radical prostatectomy is more beneficial for prostate cancer patient. So there was a systemic review and meta-analysis, and it showed that robotic is superior to laparoscopic technique when we talk about the operative time, blood loss, transfusion rate, positive surgical margin, nerve sparing, and recovery of complete continence of urine, as well as the erectile function. So no, this study concluded that robotic is superior as compared to laparoscopic technique in everything. Even it is superior to the open technique in all of the above parameters.
Voici une autre étude comparative qui permet de voir clairement que la méthode utilisant la robotique est supérieure à la fois à la méthode utilisant la laparoscopie et aussi à la méthode traditionnelle.
So nowadays we are doing this new technique. So earlier we had some problems related to the erectile dysfunction and their continence because of the retropubic approach. Now there is a new approach that was introduced by Bouchardy. So basically this is called as the Retzius sparing approach, where we go in retro vesicle and do the surgery in totality from the retro vesicle. So we don't even go into the Retzius space here. We directly approach from here, and all of the surgery is done from the from the back of the bladder.
Nous pouvons voir aussi que cette approche permet de ne pas avoir besoin d'être trop encombrant lors de l'opération. Tout peut se faire à la périphérie.
So the advantage of this procedure is the erectile dysfunction is very, very low because the nerve preservation is fantastic. And also the urinary continence rate, the control of the urine is also very good. So that is the reason it is now the preferred approach for doing a radical prostate.
L'une des raisons aussi pour laquelle l'approche c'est qu'elle a moins d'incidences négatives en ce qui concerne même les nerfs qui sont très peu touchés, donc cela et la fonction urinale.
So the main thing in the surgery that we need to take care is that we should not be giving a lot of heat to the area where there is the nerves that are there for the erectile function of the patient. So we should not be using a hot chair. That means we should not be using current or heat in that zone. So we use clips as well as we do cold cutting, and that will be demonstrated in the video that I'll show it to you.
Donc, nous allons voir bientôt dans la vidéo qui va suivre les pratiques à faire et les pratiques à éviter.
So coming to the pelvic lymphadenectomy, so the standard lymphadenectomy is obturator plus external iliac. But what is recommended is the extended, where we take out the obturator, external iliac, internal iliac, and with the triangle of Marcel, that is lateral to the external iliac artery. So that also we take it out, and presacral may or may not be included, and the common iliac may or may not be included. But it is we should be taking out the obturator, external iliac, internal iliac, and the triangle of Marcel should be taken care of.
Donc, nous avons des facteurs de positivité en ce qui concerne la lymphadenectomie pelvique. Donc, nous avons le volet standard, le volet étendu, le volet super étendu.
So to summarize, surgery remains the first choice treatment option for patients with intermediate risk, as well as the first treatment choice for patients with a high risk disease, along with the multimodal treatment. That means we might need to give some hormonal treatment after the surgery, as well as we might need some radiotherapy also to give the best advantage of the treatment to the patient. Robot remains the most popular and the best surgical platform. And Ritzius sparing technique that I showed, Bosciardi's Ritzius sparing technique, it promises earlier return of continence and potency. And the extended pelvic lymph node dissection is the minimum that we should do, except for if it is a very low risk disease. It is not warranted to do such an extended lymph node dissection, but otherwise it is warranted.
Donc, en résumé, nous pouvons dire que la chirurgie remet le meilleur choix pour le traitement avec les patients qui ont un risque immédiat ou les patients qui ont un risque élevé. Et la robotique est la technique la plus recommandée pour cette chirurgie. Et nous voyons aussi le RESUS qui est une technique qui donne des promesses de meilleurs lendemains.
So I'll be displaying the videos for the laparoscopic and robotic radical prostatectomy in a while now. And this is the robot that I got training from at the cancer center. This was the Da Vinci SI system on which I got trained. And currently we are using the Da Vinci XI, which is the latest robot that is available in India.
Nous allons voir la vidéo avec les machines avec laquelle j'ai été entraîné. Donc, c'est la DaVinci XI, qui est un système robotique. Donc, nous allons voir cette vidéo pour voir comment elle fonctionne.
So this is what I have planned for in the future. So we can have, depending on how the audience wants, we can go in for bladder cancers treatment, renal tumors, testicular tumors, cancer penis, upper tract TCC, adrenal gland tumors, kidney transplantation, and then resume urolift, iTend, HOLEP, vesicovaginal fistula repair robotically, vaginal ward prolapse surgery, female incontinence surgery, and penile prosthesis surgery. So, we can cover these topics in the future. That is what my proposal is.
Donc, en fonction de ce que l'audience veut, voici quelques sujets que nous pouvons couvrir pour les prochaines fois, que ce soit le cancer de la vessie, les rumeurs, les tumeurs rénales, les tumeurs de testicules, le cancer du pénis et autres. Donc, en fonction de ce que l'audience veut, nous verrons quoi couvrir lors des prochaines rencontres.
So please note down the number. This is available on WhatsApp, and that's my website. And whatever I'm sharing to you on the in the videos, you can check out these surgeries from. So I'm showing the abbreviated version because of the paucity of time, because of less time. But you can find the full videos, 2 hours videos of these surgeries on my website. So within, I think, 2-3 days, it will come live. So you can check out there. So I will request the audience, if they want, they can check out into the website, and they can contact me on this number. And I'll be sharing the
Voici,
videos shortly. Yeah.
Voici mes coordonnées. Vous pouvez me contacter même sur WhatsApp. Il y a aussi mon site web que vous pouvez visiter et vous pouvez nous contacter pour toute question que vous avez. Et la vidéo va suivre incessamment.
Okay. So I think the talk is over. So I'll go on to the video. So I'll just put this off just a sec.
Nous allons finir avec la présentation. Donc, place à la vidéo bientôt.
So are you able to see the screen still?
Yes, yes, doctor.
Can you see the laparoscopic radical prostatectomy, the videos there?
Yeah, yes, doctor.
Okay, so I'm just playing. If there is some problem, please let me know. So I'll try to, to just speak about the video, even though the captions are also there. At least in the first video, second video, I couldn't get the captions, but in the first one, it is there. So I'm just putting it on. So this is basically the incision that is done in the retrovesical pouch. And this incision is done laparoscopically by the scissor, and the vas difference is identified. So this is the left side vas, and now we are going in for the right side vas difference identification. So the seminal vesicle is also dissected posteriorly. So we take it out, we dissect the seminal vesicle along with the vas difference on the respective sides. So you can see this is the right vas that is being pulled. So the patient has to be in a Treadlenburg position whenever the surgery for the prostate is to be done. And the port placement is basically the camera port is there in the center, and then there are 2 pararectal ports at the same level at the umbilical, just supraumbilical level, and then there are 2 small ports that are there for the assistant in the left and right iliac fossa. So now, once the posterior dissection is done, we go in for the dropping of the bladder, and you can see this is the obliterated umbilical artery that has been cut so that we can put the bladder down. So this is the prostatic fascia, that is it is the levator fascia that is being cut on the right and the left side. So this is the right side approached now. You can just see the levator muscle on the right side where the scissor is working. And now this the DVC, I'm cutting the DVC, and that is too without taking a suture. You can just see that the DVC is being cut, and it is not bleeding because I have increased the pressure in the peritoneum to about 18 millimeter of mercury. And this, you can see the DVC is being sutured. And you can beautifully see the prostatovesical junction after this thing. And now we come in towards the prostatovesical junction. That means the upper part of the prostate. So yeah, this was coming in my vision. So I have cut that the obliterated umbilical artery there. Now this prostatic vesical junction is cut anteriorly. You can just see there is a shearing force that is being used. So I'm using a cautery, I'm using a shearing force and trying to take the prostate out anteriorly. And you can just see that the catheter is now visible. So we are at the level of the urethra anteriorly. So once I find the catheter, I'll just try to pick it up and take it out into my screen and give traction upwards. And this will give me counter traction. And you can just see the nodule. That was the median lobe that you could see. Now I'm cutting posteriorly. This is just the posterior part of the dissection at the prostatovesical junction. Yeah, so now I'm trying to enter into this area posteriorly where I'll find the vast difference and the seminal vesicle, and I like to pull them up into the into my vision, so that only the lateral pedicles of the posterior and lateral pedicles. So you can see the vast difference has come out into the vision now. So we do this for both sides, and now you can see that on the posterior pedicle, that is the posterior prostatic pedicle, I am I will apply clips. So you can see the clips being applied on the left side, and I'm not using current here. I'm just using a cold cutting. So this is preserving the nerves for the erection, as well as it helps getting the. So this is the right side posterior prostatic pedicle that is being clipped and cut, and you can see I'm not using cautery here. I'm just using the cold cut. Now this is the prostato-urethral junction. So you can see the catheter coming out, and this is we cutting the urethra in totality. So here the urethra has been cut. Now the prostate is only attached at the level of the apex. The apical dissection is going on. So we just separating the prostate from all sides. And now this is nearly the last part of the prostate that is being cut from just above the rectum. So this is having a high chance that we can injure the rectum. So we have to be very careful. And after this cutting is done, you will see that there will be somebody who will be introducing the finger into the rectum to just see the integrity of the rectum. That the rectum should not have been damaged. So we need to. So you can just see that the finger has been introduced into the rectum now, and you can just see now. And after this, the specimen is separated, and this is taken out. So once this is done, hemostasis is confirmed, and we use gauze piece and irrigation. And now this is the Rocco stitch that we give before starting the suturing, so that there is no tension on the vesico-urethral anastomosis. So this is a 3-0 V-lock suture that is being used for the Rocco stitch. So we suture the perivesical tissue and the peri-urethral tissue together and bring the bladder as well as the urethra very close. So as I said, if you want to see the full video, it will be available. So this is the vesico-urethral suturing that has been started by a 3-0 V-lock double needle. So we use our double needle V-lock suture. You can see this is the right side of the posterior plate that we are suturing here. And then we go on to the left side posterior plate suturing. So this is the left side posterior plate suturing that is going on. And this is near completion of the anastomosis. So once the anastomosis is done, if there is a bladder neck is open, we do a tennis racket closure of the last part. And this is, we inflate the bladder and check if there is any leak. So there's a bladder leak test. And now we go into the right pelvic lymph node dissection. And harmonic is a very good instrument that it is using ultrasonic energy, and we will we'll take out all the lymph nodes by the use of the harmonic. So you can see that is the external iliac artery that is seen. This is the artery of Marseille, and that I was talking about. This is the triangle of Marseille on the right side, and this is the obturator nerve that you can see. The whitish structure is the obturator nerve. So you can see it like a string of guitar here, and we take out all the lymph node packet that is there in this area, the obturator lymph node, the external iliac, the internal iliac lymph node. So all of these lymph nodes are removed, so that makes it like so you can see the bare external iliac artery pulsating, and the obturator nerve white cord like thing that you can see down there. Now coming on to the left side, pelvic lymph node dissection. So similarly, the dissection proceeds here also. So you can just see the artery, all the lymph node packet that is above the artery is taken care of. Of course, there's a big role of the camera person here, because you are totally dependent on the camera person to show you the proper vision. And also you might need some assistant to grasp sometime and do a counter traction or suction sometimes. So you can just see that there's a nerve that is there in the vision here. You can see the obturator nerve here, and here is the external iliac artery, and the vein is there down below. So you can see all the lymph node packet that has been taken out. And now this you can see beautiful lymph node dissection. And this is the vein here, external iliac vein. That's the lymph node packet that has come out. So after this, we take out the specimen, and this is the drain that is kept here. So now going on to the robotic prostatectomy. So this is the last part. And as I said, if you are interested in watching, can you see the new screen now? Hello?
Yeah, yes, doctor, we
Okay,
can see.
okay. So now this is the robotic I'm showing. So as I said, if you are interested in seeing the full videos, that will be available on my website, on the YouTube, after like 3 days time. Just give me 3 days time. I'm just uploading that, and you'll be able to see the 2 hours video for both. You can see everything technique wise there. So this is I've started from the robotic technique. So
Cette
more or less,
fois-ci, nous allons montrer la vidéo avec la technique de la robotique. Et si vous voulez avoir accès à la vidéo entière qui fait plus de 2 heures, vous pouvez la retrouver sur le site et elle sera disponible dans 3 jours.
So again, the posterior dissection here, the bilateral vas deferens is cut. Now this is, and the seminal vesicle is separated. Now we are, so here, this is a video where I have been training one of my residents, and that is why you'll find the green lines on the, so where, just to show, this is, where the cut has to be made. Yeah. So this is excellent vision that you get. This is the perivesical area. Anteriorly, as you can just see, this is the fat that is taken off the prostate gland, and you can see the beautiful this puboprostatic ligament. This is the puboprostatic ligament here, and this is one of the puboprostatic ligament on the other side. And this is the levator muscle here, levator ani, and we are cutting in and just separating the prostate from this. So this obviously takes much less time when we compare it with the laparoscopic technique. Laparoscopy definitely is much more tedious, and it's very tiring. Because a long surgery, intracorporeal suturing is a lot, but robot gives you that advantage, that precision, that unparalleled vision. You can just see See, this is the left side levator fascia being cut, and now we going in, and this you can see is now we are ready to do the cutting at the level of the this is the prostatovesical junction being cut now. So here we haven't addressed to the DVC first. This we are first doing the prostatovesical junction. So you can again see the prostate, the catheter has come up. It will be pulled up into the screen. Now we go into the posterior part of the dissection. You can just see the green lines because I've been guiding one of my juniors to go in doing that surgery. And this is the the posterior part of the dissection, the prostatovesical junction being taken care of. So this we are trying to reach the posterior part where we'll find the subanal vesicle as well as the vas deferens here. So the best part of the robotic is you're not dependent on the. So this is the one of the subanal vesicle and the vas deferens that has come up in the screen, and now we are left with the posterior pedicle. So here you can see again the current is not being used. We just current is minimal. We just trying to do it with the cold cut. So that's clip applied to not to damage the neurovascular bundles. This is nearly the last part of the prostate dissection, the posterior part. You can see the bleeding just because the cold cautery is used. The current is avoided where we are expecting the nerves to come. So that is the reason you have some bleeding here, but it's not much because you're seeing like a 10 times magnified vision. That is the reason you appreciate right, so it's bleeding. So anytime there's bleeding, we increase the pressure to like 18 or 20 millimeter of mercury. So now, once that dissection is done, we come on to the dorsal venous complex, and again, without suturing, this is being cut. You can see some bleeding, but then this is taken care of by the increase in the pressure, intra-abdominal pressure, and so the advantage of doing the cutting without taking a suture initially on the DVC is then we can save a very good length of urethra for the anastomosis. And you can see that this is the suturing that is going on, the DVC being sutured now. And so this is the prostatourethral area. So now we're trying to get the max. Can you see this big length of prostate of the urethra that has been saved here? So this is the length of the urethra. So we just do the whole of dissection, and now the prostate is out, and now we proceed with the vesicourethral anastomosis. So this is here we are not taking any Rocco stitch or anything, because suturing in with the with the robot is quite easy. So this is a double needle V-lock suture, and now the urethral anastomosis, the psychourethral anastomosis is going on. So again, once the anastomosis is done, so we try to do a mucosa to mucosa anastomosis, and once that is done, we introduce the catheter before closing it totally, and inflate the balloon, and then try to inflate the bladder to do a leak test, so that it is not leaking from. So you can just see this catheter is now being introduced inside, and once this is done, we complete the anastomosis and then do the leak test, and that is, you know, so this is the last bite, and now we go on for the pelvic lymph node dissection, like we did it in the laparoscopic technique, and then we take out the specimen. Yeah. So thank you so much for patient listening. I am open to any questions, if at all, that there.
Doctor, we
Merci
have
à
one
tous
question.
pour votre patience et nous pouvons passer aux questions maintenant.
Doctor, we have one question in the chat. Dr. Navala Gabriel has asked, what is the average cost of robotic surgeries?
Okay, I'll tell you. Just a sec. Let me open up that chat. Yeah, okay. So it's so average cost of robotic surgery is like, at least approximately, I don't know how much it is in dollars. I think Shivanshi will be able to convert it. So normally what we offer to the patients is something like 8,700 approximately the US dollars for the surgery, robotic surgery. Hello.
Yeah, Yaobi, can you please translate this?
Hi, Dr. Amit, can you please say the price you gave again, please? I
So
couldn't.
it is something like
Oh.
8,700 US dollars approximately. It is not the
D'accord.
difference. It is the total. It is the total cost of surgery.
D'accord. Le prix total peut être d'environ $8,700.
Yaobi, you can ask the doctors if they have any questions. They can put it in chat box or they can ask the doctor directly.
So
Si
I have
vous
put
avez
the
des
cost
questions,
in robotic.
vous pouvez les poser directement ou écrire dans l'espace message.
Hello. Yeah. Is there a question?
Yeah, doctor, we can just wait for 1 to 2 minutes if we get any questions.
Sure.
Doctor, we can do one thing. If
Yeah.
someone has any questions, I can club them and I'll then send it
Yeah.
to you.
So Shivanshi, what I like you to do is just try to form a group of all the doctors who have connected, so that we have
Okay.
a group. And if there are certain queries that they need to, to address to, I'll be definitely very happy to answer. So
Yeah,
if
sure,
you can
doctor.
do
Sure,
that,
doctor. Wait.
please do that. Okay.
Yes, sure. Thank you so much, Dr. Amit, for the insightful presentation and for taking out your time for webinar. Thank you so much, doctor.
Thank you so
Thank
much,
you.
everybody. Thank you.
Yeah, thank you so much, AIOB, for the translation, and thank you so much, everybody, for attending.
Merci à
Doctor, we have,
tous pour votre participation.
Thank you, Doctor.
Doctor, we have one more question, if we can take it.
Sure.
Yeah. What's the management of metastatic prostate cancer?
So, metastatic prostate cancer, as I said, can be a metastasis to the bone or any other visceral organ of the body. So, it depends on where the metastasis is. So, more or less, the treatment is bilateral or orchidectomy is still indicated in the patients who do not want to spend money on the injections. We can do a bilateral orchidectomy also. So a lot of patients do get it done, but it works as good as any hormone therapy injection. So it is the same. But for any patient who has a metastatic disease in the bone, if there is pain in the bone there, if there is a risk of fracture, we sometimes we need to give some bone strengthening injections to the patient, and we also need to give sometimes radiotherapy to the bone if it is a weight bearing bone. We also sometimes if the patient has become castration resistant, that means if it is become hormone resistant, in that case we sometimes give the patient abiraterone or enzalutamide, or if there is a visceral metastasis, and so we sometimes give chemotherapy also to the patients. So not nowadays a lot of immunotherapy has also come up. So that is what I said. It is such a big spectrum of disease that telling everything in one line is actually very difficult. Hello.
Yeah, Obi, there is one more question. Dr. Yannick has asked, can you please translate it? It is in French.
Okay, Dr. Amit, so one participant is asking, what are the survival chances after uh, a surgery treatment of a patient that has adenocarcinoma of prostate, and is there a possibility of recurrence?
So so we do surgery mostly in those patients where we are expecting cure from the disease. So the primary treatment of doing a surgical treatment is, after investigation, we look at curing the disease. Yeah. Hello.
Première
Yeah.
chose à
Yeah.
considérer, c'est que nous décidons d'un traitement chirurgical si nous sommes convaincus que cela permettra de guérir la maladie.
Okay. But the patient needs to be on constant follow-up. So every 3 monthly to 6 monthly, the patient needs to do PSA, and we need to assess the disease. So there are definitely chances of recurrence. We nobody can say that once the surgery is done, the patient will never have recurrence. The recurrence does happen, and that is the reason we say that it is a cancer, right? So the cancer name in itself it is telling you that it can recur, and that is why we dread having cancers.
La nature même du cancer rend le fait que ce soit récidive possible, mais nous faisons des suivis assez réguliers chaque 3 à 6 mois pour déceler ces signes de récidive et procéder à une meilleure prise en charge. Doctor, there is another question. I think this must be directed to Shivangi. So they're asking, when will the certificate of participation be given, and how will that work?
Yeah, we tell them that we will give the certificate of participation between 3 to 4 days.
Ok.
Yeah.
Le certificat de participation vous sera envoyé dans 3 à 4 jours. Donc, vous recevrez sûrement dans vos mails. Merci.
Yeah. Thank you so much, Dr. Amit,
So thank you so
for the
much.
presentation, and thank you. Yeah, thank you everyone for attending. Thank you so much, Doctor.
Thank you.
Merci à tous et au revoir.